What a beautiful crowd. Thank you all so much for coming out on a Saturday afternoon to support your local independent bookstore.
Yeah, and our local friends.
Way to celebrate.
Look at that
face. Book Passage is really a cultural centerpiece for the Bay Area and beyond, and we appreciate your support, and it's the reason we can have incredible authors like you today, so thank you. This afternoon, Book Passage is proud to welcome Sharon Kaufman, preeminent medical anthropologist, acclaimed lecturer, author, and chair of the Department of Anthropology and Social Medicine at the University of California at San Francisco. Sharon is with us to talk about her latest, very important book, Ordinary Medicine, Extraordinary Treatments, Longer Lives, and Where to Draw the Line. This book is a critical examination of modern healthcare treatments and the dilemmas they often present to an aging society. Publisher Weekly writes this review. Medical anthropologist Sharon Kaufman bravely delves into the heartbreaking predicament of modern medicine. Getting the medicine we wish for, but then having to live with the unsettling and far-ranging consequences. Kaufman calls for no less than making the ethics of medicine the preeminent topic of our national conversation about healthcare reform. So with that, please help Book Passage warmly welcome Sharon.
Thank you, everybody, for coming out on a very beautiful day to think and talk about a vexing topic. Well, I think most everybody here, many people here know that I've been deep in the trenches of medicine and healthcare delivery for a long time, for nearly 30 years now. And for a great part of that time, I've been paying attention to what I'm calling the quandary of the line. So what is this? It's the fact that medicine has extraordinary technologies, treatments, procedures that can save life and that can keep us alive for a long time, and we want this, and many of us are living longer and better because of medicine's breakthroughs and the improvements in procedures. On the other hand, the complaint about medicine has never grown louder. It is just, it's everywhere. You see it everywhere. It's all over the media and the newspapers and the blog sphere. And what is the complaint about? Well, it's about the fact that we want all these techniques and we want our lives to be saved and prolonged, but we only want them to be prolonged if it's going to be a good life. And we don't want dying prolonged. The problem is nobody seems to know exactly where that line is between too much treatment and enough treatment. Now, doctors in our healthcare system should be the ones who know exactly where this is. Doctors are in it all day long. But the truth of the matter is, as many of us know from our family situations, they don't know, and they can't often advise us exactly when to say stop or when to say let's do this. It will improve life unequivocally. So the burden for deciding where the line is mostly now often on patients and our families. And this is a huge burden. And one of the things I've learned by hanging out in clinics, like a fly on the wall and an investigative reporter and someone who asks research questions, is that this burden is getting ever more complicated. It is reaching into our deepest emotions about love, obligation, and responsibility, about what we owe our families and what we owe ourselves, and about where our society should be going. So when I realized the depths of individual patients and family members' angst about this, I became very perplexed. I thought, this question of the line is burdening more and more people, yet everybody seems to be isolated in their own understanding of this and their own way of trying to figure it out. It is a sort of problem of shared privacy or a public secret. So many people are going through this quandary, yet we can't seem to learn from other people's experiences. And I wanted to write about it. I thought, if I could pull together the thoughts people are having and what they say, their voices, about this quandary, maybe more of us could learn exactly what it is, and we could learn from other people's experience. So the project really started, ordinary medicine started with my previous research, which was in the hospital. Because there, of course, is where the end of life mostly takes place for most Americans. Although we claim we don't want to die in hospitals, most of us are dying in hospitals. And I wanted to investigate why that's the case. So I hung out in hospitals for a long time and with a notebook and a pen, and I wrote down everything I heard and everything I saw. And what I learned was that the system itself is so powerful, and individual patients or their family members have to be so strong in defying the more is better ethos that it's very hard to say no. And so people end up in the intensive care units, or people end up being attached to those tubes and machines we all claim we don't want. But the system moves in that direction, and it's hard to know where to draw the line. But while I was doing that project, I realized, this quandary is much bigger than the hospital. It goes way beyond hospital walls. And I decided, really at the beginning of the new millennium, but into 2003 and 4 and 5, that I wanted to start paying attention to the healthcare interventions, the procedures that more and more older Americans were receiving, and were receiving often, all the time, in an ordinary way. So I started hanging out outside of the hospital in clinics where people were coming for discussions with doctors about kidney and liver transplant, cardiac implantable devices, advanced cancer treatments. And I started to pay attention to the language people were using in those clinics. And I want to say, being an anthropologist and being a medical anthropologist is a great privilege. I have the opportunity daily for years to listen to people's most serious conversations about their life, about their families, about growing older, and about this society. And because I have been paying attention to the Medicare population, in other words, as we grow older, we're the ones who need more medical care, and we're the ones who are going to the doctors more often, I've been able to really be in the room with a huge cross-section of Americans, because as you know, once you're eligible for Medicare, health insurance is paid for. So you don't have to be rich to receive any of these procedures, you just have to be Medicare eligible. So I started hearing language about evidence, norms, standards, and I heard from a number of doctors that doing nothing is non-standard. That's a direct quote, and I heard it more than once. And I began to realize, wait a minute, what's going on in the clinic when these intimate, private conversations are going on? Should I have an ICD, the little thing that's like a pacemaker that can stop sudden death? Should I go forward with trying to get a kidney or liver transplant? Should I start another round of chemotherapy? What I started to realize is the way in which all of these therapies were organized started way upstream, way outside the clinic space, and that doctors could only offer what was already standard and what was considered necessary, and that patients therefore had choices among all of the things that were available, that had become standard of care practice, and that were now ordinary. So I realized I needed to look farther upstream into the biomedical research engine, the clinical trials business, the way Medicare operates, and how standards of healthcare are actually becoming standard. And when I realized that there was a direct line, a direct connection between the biomedical research engine and what patients were deciding, what we and our families were deciding in the clinic, that's when I decided I wanted to write this book. And I realized that so many of these procedures and treatments had become so ordinary and normal for people over the age of 70, 80, and 90, that's when I thought of the title, Ordinary Medicine. In other words, these are extraordinary treatments that in the last 10 and 15 years have become standard, ordinary, and because of that, have become morally necessary. It's very hard to say no. Now, on the one side, why would we want to say no? These things are life-sustaining, and we want that. We all want that. We all have one life, and we want to preserve the lives of our family members. On the other hand, the complaint is really loud. So, let me tell you what I started to discover. And I've been working in healthcare and a medical center and a medical school for a very long time. Yet, when I started to connect the dots, I realized a lot has developed in our healthcare, our wonderfully fragmented healthcare arena over the last 15 years. First of all, there's more private industry influence on what happens to us, okay? So, for example, in 1980, private industry, and that means the pharmaceutical, device, and biotech companies contributed 30% of the dollars to medical research, the research that ends up in treatments that finally eventually become things that we have access to. 30%. Today, it's 65%. So, and I think everybody knows that the reach of the pharmaceutical industry, of course, is large. We all know about that. There's critiques about that in the newspapers every single day. But what you may not be aware of is that the growth in the device industry market has shot up. The graph goes like this in the last decade. So, what's happening is that private industry is funding more and more of the medical research and the clinical trials that are taking place. As a result, more and more evidence is created showing that all of these devices, drugs, and procedures are useful. And they are. I mean, this is why it's so complex. They are. But it's really important to know that private industry is having a larger say than ever before. And let's face it, the bottom line is the market. They want to increase market share. They're interested in expanding their markets for their drugs, devices, and procedures. And who's the market? The growing aging population. So, the influence of industry. The second thing is, industry is churning out more and more clinical trials with more and more treatments. And we've never had such a large array of options. And I think one of the best examples of this is in Atul Gawande's wonderful new book, Being Mortal, which I think many people here know about and have read. You remember there's a passage about 2/3 through the book where he's talking about his father's spinal tumor and what to do about this and how can the family deal with this and how can the family be supportive. So he's a doctor, his father's a doctor, and his mother's a doctor. So you've got the three physicians who are the patient and the family. They go in to see the oncologist who is going to recommend treatment. Well, because there's so many clinical trials now churning out so much evidence and doctors pay attention to the evidence, and we want them to, the oncologist said to the family, there's 8 kinds of chemotherapy you may choose among. Here is what they all do. And she rattled them off. Then he writes about this. Then the oncologist listed the combinations, and my mathematical son in the audience can figure out the probability, how many combinations there can be from 8 different kinds of things. The combinations of 2, 3, or 4. And the oncologist rattled all of this off. The family, of course, all of whom are physicians, didn't understand anything the oncologist had said. They were totally perplexed and were absolutely unequipped to make a decision. And I've seen things like this all the time. We have a lot of options today. The burden on decision making has never been larger. And because physician paternalism no longer exists in the way it did 40 years ago, and on the one hand we're very glad it doesn't, on the other hand, there's a huge burden on patients and families to choose among the array of what's offered. So, more treatments, more industry involvement, and of course, a greater older population. The baby boom generation is now turned 65 and older, and the age group age 85 and up is the fastest growing age group in the United States, as well as in some other countries. And it's this age group, this cohort, that is the audience and the patient population now and in the coming years who will be having to make these choices. So that's the big picture. That's the scene in which we're all situated. We're all sitting in this scene. And that's one part of the story that ordinary medicine tells. But I want to turn to the book.
She hasn't used OneNote yet.
because I want to read to you some passages from the other part of the story, which is the intimate emotional entanglements of individuals, and not just patients, but their family members and also their physicians. So because I hung out for a long time in a lot of different clinics across the US, I want to add, mostly in California, but also in other parts of the country, I heard a lot of anguish and worry about what should we do, who's going to decide, how can we decide, and how, as a family member, can I express love for the person who I'm bringing to the clinic, who is now a patient. So the second part of the story is these intimate tales, verbatim, that I heard in the clinics. So the first example of the dilemma of the line is from a lovely 86-year-old man who I met in one clinic. So he had an ICD, this little thing that goes right here that's easy to insert. So the ICD came into existence, into use in 1985. And when it came aboard, it was used for younger people mostly who had already had a lethal cardiac rhythm, and it jolted the heart back into a normal rhythm. The ICD is also called a crash cart in the chest. So it operates like that, but guess what? It's on a computer chip. So, electrical. So it was used sparingly, not very often, and certainly not often for people who were older. But because of this perfect storm of what's come together, industry, influence, more clinical trials, more evidence, and an older population, between 2000 and 2005, there were a bunch of clinical trials showing, guess what, the evidence, good evidence for use of this device for people who had never had a lethal cardiac event. In other words, you could use this in a preventive way. As a result, more than 100,000 people are getting these every year now. So it went up from a few thousand to more than 100,000 a year. And of course, the population for this is people in later life. And I've learned from a number of practitioners that about 10% of these are placed in people over the age of 90. Now, the thing, and the ICD becomes a big theme in this book, and I call it an ironic technology, because what it does is it prevents sudden death. Now, this is a good thing. On the other hand, if you ask each other around the room, how do you want to die? Everybody will say sudden death, silent heart attack in the middle of the night, right? Almost everybody says that's how they want to die. This device prevents that from happening. So there's a great side and a dark side to all of these procedures and technologies. And that's why, people say to me, well, what side are you on? No, it's not like that. It's two-sided. Everything is two-sided, and I think we need to walk very carefully on this line as we go through the healthcare system ourselves and as we take family members in and out of various clinics. So here's what my 86-year-old companion that day had to say. After I passed out and was taken to the hospital, the cardiologist said I should get an ICD. He said he wouldn't be doing his job right if he didn't say that I needed an ICD. He told me the 2 stents I had previously were blocked, so I agreed and he put it in. Now it seems the ICD has prolonged my life a little bit, but the longer it prolongs my life, the more other things are happening to me that it can't correct. And all the medicines, all the treatments have side effects, and some of them are pretty bad. So which do you want? The question is, do you want to have the other things that are going wrong and the side effects? Or do you want to end it all, and when? I heard lots of incredible comments like this. So here is what a doctor had to say about the ICD. This is somebody who's a specialist in inserting these. Once I'm asked to see the patient, it's usually because the internist or the general cardiologist has made a determination that, whatever the age, they still want this arrhythmia to be aggressively managed with a defibrillator. It becomes very controversial sometimes, and maybe that's one of the sources of my personal unrest. Sometimes I disagree, but it's very tricky to sit down with an 88-year-old patient or their loving family, and by now they've heard about this technology, and to say, you know, he does meet the clinical criteria, but really, at his age, it may not be the right thing in this case. If he were to have a dangerous arrhythmia, well, that's the way people pass quietly in their sleep. That may be a natural moment at the end of the person's life. Sudden death is actually a pretty good way to go, so it may not be something that we want to jar your loved one with. And then he continued, but we're very powerful in our ability to convince them that that's what they should have, according to what the studies show. And I believe in these studies. We definitely convince 80-somethings to go through all this, and you let them go then from the hospital, never really knowing, except by some study or inference, whether you've really made them live any longer, whether they're just miserable at home, whether it was worth it. So physicians are in a lot of turmoil about these things too, as the age is ratcheted up for doing these procedures. So I also wanted to look at one procedure that was not high tech, low tech, been around for a long time, and that is kidney dialysis. I think folks know here, many in the audience know that between 1960 and 1972, before Medicare decided to pay for this, this was a scarce resource. This is where the ethical dilemmas were in medicine. Who was going to get this? And the University of Washington had this famous committee that became known as the God Committee, the people who decided who was worthy of being able to use a scarce dialysis machine. And who was chosen? Mainly white working men under the age of 45, the breadwinners for their families in 1960. Things have changed dramatically. Here's what a social worker who worked in a dialysis center said. Everyone has the right to dialyze today. Nothing disqualifies patients. When dialysis first started in the 1960s, it was selective medicine. Not everyone with kidney failure was placed on dialysis. Older people were looked at carefully, very carefully. Their lifespan was looked at. If they only had a few years to live, they probably didn't get dialysis because it was so expensive to run the machines. Now there's a drive to keep people alive longer, period. We look toward prolonging life a lot longer these days. Patients are just placed on dialysis and told that this is what we need to do. If a patient has cancer or another progressive medical condition, then sometimes the doctors will advise them not to start. But mostly it is automatically assumed that a patient wants dialysis. No is never presented as an option. It should be, but it's not. So today, most of the people on dialysis are over the age of 75. It's a geriatric phenomenon, and there's a great deal of controversy and debate in the medical literature about, should we do this? Should we not be doing this? There's articles in medical journals that say pro and con, and then they have a writer on each side. The same for the ICD. When you start delving into the medical literature, you see that there's a great deal of debate going on, that it isn't absolutely settled. So I think for me, the place that was the most poignant to observe was the situation of kidney and liver transplant, organ transplantation. Because today, this is the scarce resource, of course, human organs. And because surgical procedures have gotten so much better, because immunosuppressive drugs have gotten so much better, anybody can be a donor. And living donation has gone way up. The pool of deceased organ donors has remained static for more than a decade. In terms of kidneys, in the United Network for Organ Sharing Pool, which is our national pool, which has, of course, regional branches, there's about 13,000 kidneys available at any one time, and that number's remained flat. There's now 100,000 people on the waiting list. So because the techniques have become better, and because people are living longer, and because people are living healthier into later life, more older people are eligible for kidney transplants, which means that more people are now wanting to take from the pool, from the commons, so that it's a longer waiting time. And at the time that I was doing my research in clinics, if you had type O blood and live in a major metropolitan area, anywhere in the Bay Area, as we all do, The waiting time when I started my research was about 5 years. It went up to about 10. So what people learn when they come into a clinic for an evaluation and a workup is that they have to weigh the issue of time and love along with the specifics of the procedure. So older patients are told, for example, you're now 70. There's a 10-year wait for you, probably because you have type O blood. Who do you know who could be a living donor? And what I heard mostly was, I'll never take an organ from my spouse or my adult child. And what happens is, they do. So let me read to you how that works. Here's a man age 75 who accepted a kidney from his 30-something-year-old daughter. The children talked me into it. I said, I'm not taking my daughter's kidney, but other family members persuaded me. You know, I kind of went along with my older daughter's insistence, and we didn't say too much one way or the other, whether I wanted to or not. But I was hopeful that I could get a cadaver right up to the night I was hospitalized. My point was, I didn't want to take an organ from my child. If it were the other way around, I would have gladly given my kidney to one of them. But because it was coming as a hand-me-up sort of thing, I thought about it a lot. I didn't feel like it was the right thing to do. Help should go the other way, from parent to child. There were periods of time I just really didn't want to do it. There was no real point in time where I decided I wanted to have it done. I just went along with the flow. I was going along for the ride because things were being arranged for me. He had a very successful transplant, and I followed him for a couple of years, and he was living a very good life. But when I began to explore this, now of course the numbers for transplantation, both kidney and liver, are much smaller than for cancer treatments and cardiac treatments. These are in the thousands, not the hundreds of thousands. But when I started paying attention to this, I started asking people, hey, did you know that adult children were donating their kidneys to their older parents? And people said, what? And I said, yeah, this has become ordinary. Again, this is where I thought, oh, this has to be the title of the book. And when I first went in to start to find a clinic where I could observe these conversations between the doctors and the patients and the social workers and the families about how to proceed, I was ushered into a lovely office by the head nephrologist at one kidney center, and I said, I'm really interested in doing some observations here, and I'm interested in this phenomenon and what's happening to older patients and what you're doing and how you're making decisions and how patients and families are making decisions. And he said, what would you do if your father needed a kidney? So this was great. This was the right question, because my father at the time was 85 and slightly out of the range for older persons receiving kidneys. But actually, since then, I've learned that a couple of people over the age of 90 have received kidneys in American hospitals. But when he asked me that question, my first thought was not about my father and what his need for a kidney would mean. It, of course, went directly to my children. I thought, well, what if one of my children needs a kidney? So I was immediately caught in this intergenerational tangle, this multi-generational tangle of love, obligation, how do you express it, whom do you express it to, and when, and how medicine is provoking these dilemmas in families in a way that it never has before. So here's what somebody who was eligible for a liver transplant, a much more costly and complex procedure, had to say. This is a man that I call Adam Carter, and he had been having, he had hepatitis C with bad symptoms for 17 years by the time that I met him. So he said to me shortly before he received part of a liver, I knew that hepatitis C could turn into liver failure. At the time, my wife and I thought, what a great thing to have a transplant as a possibility in your back pocket. This was a couple years before I met him. Isn't this wonderful? If it should be necessary. It seems so remote. And I thought I was of an age, he was 75, Or I may never need a transplant, but liver cancer developed. And then his wife told me, by 2008, he was getting more and more debilitated. Then they asked Adam in the clinic if he could find a living donor, because that would be quicker than waiting on the list. And we would get into these awful arguments, because first, he wouldn't send the living donor information packets to our relatives. I wrote to Adam's sister, and it's the only time she never replied. And then our daughter said she'd be a living donor. And I thought, oh my God, I cannot stand the thought of that. I was so torn, so upset. We had horrible arguments, because Adam would say, I want a liver. And I said, I don't want both of you having that kind of surgery, that risk. It was hell. And then Mr. Carter chimes in. What a decision, going to a relative and saying, they're going to take half your liver and it's just as serious an operation for you as it is for me. How can you? It's the most difficult thing. But then the wife countered, but you wanted one so desperately. You would have taken it from her. And then, of course, our daughter took forever to get her blood tested, and that was a very stressful time. I nearly lost my mind, and thank God she wasn't the right blood type. So, I've had the privilege to listening to these difficult conversations, and nobody knows that other people are having the same conversations. And I thought, well, one of the things I want to do is let people know that this is a shared experience, and maybe people can learn. But the other thing I wanted folks to be able to realize and to be able to see in detail is the way in which the press is always for more, and how difficult it is to say no. So I want to read one more, and because through all of this, of course, I've also been thinking about cost, and the cost of healthcare is a huge topic of public policy and national debate today, and of course, the Medicare system is constantly being threatened and everything else. So it's made me think a lot about, well, what happens in an aging population where Medicare, with no age controls and cost controls, which is its beauty and perhaps its future downfall, is enabling us to have the right to get these treatments at ever older ages. The age for every procedure that I've observed keeps going up. So when transplants first started, no patients over the age of 55 were considered. Now it's in the early 80s, because the procedures are better, the immunosuppressive drugs are better, and people are living healthier longer. So I talked to a wonderful transplant surgeon about this, and he really said in a paragraph, he really put it together for me, the issue about social justice and individual rights and individual need, and the problems that physicians are facing, as well as patients and families. Here's what he said. I had a patient who was listed at age 67. He waited 8 years on the UNOS list and came to the top of the list at age 75. The kidney offered was a 30-year-old kidney. The second patient on the waiting list is at a hospital nearby, and he's 29 years old. The kidney is definitely right for him. What am I supposed to do? That kidney is also the right one for my patient. It will work right away. He'll spend less time in the hospital, thereby saving money. It will improve his health and his life. But what's right for my patient is not right for society. This happens all the time. 70-year-olds are getting 40-year-old kidneys a lot. I wish someone would stop me from taking that kidney for my 75-year-old patient, but I gave it to him. So I wanted to give you just, a little hors d'oeuvre about the kinds of conversations that I was privileged to be part of, and what patients and doctors and family members told me about what they were agonizing about. And I want to end by, before opening it up to you, because we're all participating in this experiment about where medicine is going and how it is changing our lives. I want to end just by saying that I think it's really important to be aware of how the medical choices and options that we are faced with are not just changing healthcare delivery and raising the cost of healthcare delivery, they're changing us. they're changing how we come to understand what normal aging is and what ordinary aging should be like and what longevity making should be. And they've opened up this door for us to seriously consider how we need to and want to be involved in this process. And the big thing that I learned, the most poignant thing I learned, is because all these procedures are so complex and wondrous and they save wanted life, they also raise these huge issues for family members about what is my obligation as a family member. Should I support my patient in getting this, in wanting to have this, or should I be more aware of the line? So the issue of love, obligation, guilt, complicity in going forward or not going forward, this looms really large for patients. And medicine has opened this world of emotion to us that really didn't exist 15 or 20 years ago. And I wanted more people to become aware of this. That's the story of ordinary medicine. Thanks.
Couldn't have been better.
Well, I don't know if anybody has a question or a comment. In the sweater, yeah.
Yes, I'm just wondering about the burden, the financial burden on Medicare itself and how that's shaking out with all these increased options for
Yes.
older patients. And coupling with that.
Repeat the question?
Yeah, the question was, how is this shaking out for Medicare, the cost burden? Well, it is. It's a growing cost burden.
Yes, and I was going to add, and how does, I don't know if people with cirrhosis can get new livers, or what about people who have been lifelong smokers? How are they looked at by the medical community?
Well, there's a lot of committees, and they debate every individual patient case. And it's different in every medical center. One of the things I've learned is there's no...
Just the mic.
Sorry. So there's, the woman asked, what about cirrhosis and different medical conditions and how are those handled for transplant? And I just want to say one of the things I learned is that there's no national rule about this. Different medical centers handle it differently. And I learned just simply for the age of the patient that different hospitals have different age cutoffs or no age cutoff at all. And this is mutable. It can change over time. So there's no hard and fast rule about the specific medical condition. But what physicians and the social workers and all the planners, all the multidisciplinary team who's always involved in any of these things, a device as well as a surgical procedure, they weigh all the entire medical condition of the patient against what the evidence is showing about whether this intervention will work. And there's no hard and fast rule. Yes, hi.
What do you think about Ezekiel Emanuel's declaration that he's going to cut off any kind of intervention?
Okay, the woman up front asked, what do I think about Ezekiel Emanuel's big article in The Atlantic at the end of next year that I think the title was, I will stop receiving medical care at the age of 75. I think people saw this. Well, it's an example of our national preoccupation with control over the timing of death. It's absolutely become a national preoccupation. Ezekiel Emanuel is right now provost for the University of Pennsylvania. He was one of Bill Clinton's healthcare advisors. He has worked for the Obama administration also, and he writes often for the New York Times and other public outlets. He's an oncologist actually by training and an ethicist. So he is 57. And he wrote an article, and you can go find it easily on the internet. His big smiling face is, he's Rahm Emanuel's brother, for those of you who pay attention to kinship, as we anthropologists do. He decided, because of this national preoccupation with control over the timing of death and our qualms about medical care and the quandary of the line, he decided to make a public statement. I will stop receiving medical care at the age of 75. Well, he said this very happily in good health, and there's a picture of him in the article. He just hiked Kilimanjaro with his 2 nephews or something. So he was in great shape. And he said, look, we're spending too much money. There's way too much suffering at the end of life, as everybody knows. There's so much complaint about the fact that medicine is not prolonging wanted life. It's prolonging suffering and prolonging a dying process that goes on and on. My decision is that I will not have anything at the age of 75 and onwards. And he listed, I won't have a flu shot, I won't do this, I won't do that, and I'll be by 75 I will have lived a great life and I'll be happy to go. Well, the blog sphere was full after that, and what I think about it is wait till he's 75. I think it's highly likely that he'll change his mind, because one of the things I've learned, especially with people who are 80, 90, 102 in clinics, and as I get older myself, life is precious at every age. Life is precious at every age, and if we want to live, we want to live, and we will do what we can, but without understanding the consequences of making that choice. So
You're dead a long time.
Yes.
On the subject of spending money constantly and spending too much money, there's a very interesting article in the Wall Street Journal and a few others that talks about decade after decade after decade, the Cancer Society spends on average $6 billion a year, year after year after year after year. Where are the results?
Well, that's another topic. All I have to say about that is the biomedical research engine is today a $100 billion engine. It has doubled in scope since 1999. See, one of the things that really fascinated me and made me look toward all of these procedures that we were now getting over the age of 70, 80, and 90 is that medicine and the healthcare engine has changed drastically since the new millennium, and that's one thing. So biomedical research continues. Private industry funds a lot of it, and the results are uneven, but there's always the promise. And I just have to say that Dan Callahan, an observer of healthcare for a long time, a very famous ethicist and philosopher, said, American healthcare delivery is decidedly American.
Yeah.
Individualistic, profit-driven, science and technology-oriented. As a matter of fact, with a romance about science and technology, and not concerned with cost. And I think that's one of the pluses and the minuses.
Yeah. Did you get involved in the discussion of feeding tubes in people that are no longer to eat?
I've written about that earlier, and I think that's another example of a wonder. I was just asked, what about feeding tubes? In other words, low-tech technology that now there's medical literature out that says that this is prolonging suffering rather than prolonging life. And it, just for people to know, one of the lovely things about looking comparatively in other countries is that the feeding tube to prolong the lives of people who are very frail with dementia, which is what we do pretty regularly here, unless somebody says no. This is not done in other countries. It is not done in Western Europe. We're the outlier for the use of feeding tubes. Kaufman.
That was an incredible talk and an incredible book. Thank you very much for that. I've got sort of a double-barreled question. One is that last passage you read about the liver transplant in the daughter just seems so integral to what you're saying in the book, and I was wondering if you could unpack, just talk more about that, because that seems like, grounds for divorce, really. I mean, they're both coming from such different, perspectives, and I'm wondering how that tends to work out, or how those conversations happen. And then the second part is, you sort of say that, yes, there are two sides to this, and I believe you when you say that, but it also seems that the way you present it, or maybe just the snickers from the audience, that people do have a perspective on this and do think that, yeah, people do get too old for some of these. So you also said that the dialysis debates came down to male breadwinners, and obviously that had a lot of cultural assumptions to it, and I'm sure if we had that debate now, we'd have another set of cultural assumptions, And so I'm just wondering,
Well, I'll take on part of that.
Yeah, take part of it.
Because there's a few other questions before we have to end. So just in terms of the daughter who offered to be the living liver donor and the mother who was so relieved that her blood type wasn't right. I heard versions of that. Now, the liver, that surgery is more complex with greater risk than kidney surgery, which is very routine and very safe. This is one of the problems. Is medicine is so successful in so many ways with such little downside. I heard a number of prospective kidney recipients come into the clinic and say, "Gee, why did they have me go to a 1-hour class? I thought this was like going to the dentist." So the procedures have become routine. They become ordinary, and a lot of assumption around it is that, oh, well, I can just go in and get one. With the liver, it's a little more complicated. But the issue of family involvement, I heard a huge range. Sometimes among siblings, there was a fight about who would get to donate a kidney. So, for example, the youngest daughter of 4 said, "Well, I'm the youngest, I'm the baby, but I'm the only one who isn't married with children, and I'm the only one who's working full time, so naturally it should be me." And they only test one person at a time, but she's the one who became eligible. So sometimes there's a fight for who gets to do this. Sometimes nobody wants to volunteer in terms of the living donor. So there's a huge range, but in every single case, there's a kind of burden of decision making that is unprecedented around this. We can talk about other stuff later. Yes, hi.
I have been urged, and I'm sure we all have, to complete a health care directive.
Mm-hmm.
I have read and heard that they are often not followed for various reasons.
Yes.
What can we do?
Okay.
to ensure that they will?
Yes, this is a big topic. But first of all, yes, look at it, fill it out, even though you won't necessarily understand how to fill it out. And I've been in this business a long time, and when I looked at the most recent version, I couldn't figure out how to fill it out. But talk to people, fill it out. The important thing I think about this written document is that it spurs a conversation, and I think that's the important thing to have, is the conversation with people that you care about and people who would speak for you if you're in a hospital on a ventilator or so ill that you can't make a decision, speak for yourself. So I think it's the symbolism of this form that is really important. It's what it enables people to do. But in terms of whether it's followed, when I was doing my previous study in the hospital, I learned that 10% of Americans have filled one of these out. But who plans ahead? I mean, it's very hard to plan ahead for this. It's very hard to project oneself into a future and decide what kind of specific procedures one will want under certain conditions. Because it's impossible, basically. But medicine asks us to do this. So 10% of people who have filled this out. Of those, 10% of them arrive in the medical chart at a time when they're needed. And of those, 10% are followed. So I don't want to say it's useless, because I think it enables a conversation, and I think that's the most important part of it, that we're all going to be patients eventually. And it's important to know what the kinds of options that are going to be available to us, and what it'll be very hard to say no to, and then what the consequences will be.
I think we have time for just a couple last
A couple more?
questions.
In the purple? Uh-huh.
I have a suggestion as a gerontological nurse. We used to call Medicare the blank check in the hospital. If you don't want a lot of hideous things done to you, when you get into a hospital, you can also tell your family members that you would like a palliative care consult. Almost all hospitals now have palliative care physicians and nurse practitioners. They are not the surgeon. They don't make the money that the surgeon makes. And try not to disabuse yourself of the notion that money isn't at the root of our medical system as it stands today, because it most certainly is. So palliative care consult, remember that term. Or if by some miracle there's a geriatrician in the hospital, someone who actually specializes in older adults, that's your other advocate. Because your surgeon is not your advocate. They make a lot of money. Now, some of them may have ethics. I worked in the hospital 10 years. I'm just saying.
Thank you. One more? We'll take one more? Yes.
It's kind of a different topic, but there's so much medical information and misinformation on the internet. How do you think that's affecting people's feelings about what kind of decisions.
That's
they should
affecting
make.
us to a great extent. So one thing is the advertisers are incredibly savvy, and it's very hard to tell the difference between an advertisement and an actual medical site. Really hard to tell the difference. So that's one thing. On the other hand, we've all become much more savvy, and we're all internet aware, and you hear you've got some diagnosis. What do? You go home and you look it up and you read everything there is, and print it out and take it into the doctor and say, hey, have you seen any of this? And I've learned from physicians, some of that information is 15 years old. A lot of it is completely wrong. A lot of it is to sell a certain drug, but the way it's presented, this is a sophisticated industry. So, I think you can't make a medical decision based on what you read on the internet. That's all I have to say about that. I mean, we're all, led. On the other hand, patient decision making. We are members of the healthcare team now. It is our responsibility to know a lot about healthcare. That responsibility is a big burden. So it's this weighing that has become part of the problem today. Yes.
In your work all these years, have patients ever come to you and wanted to speak about a fear of death? Yeah, I mean, what drives people to want this continuing life if there's not a good quality of life? Why be an old person if you have no quality of life? Where is the fear of death? Because I think this is a great American thing. People are afraid of death. Youth is right on top.
Yeah, but what I've heard in the clinics is that because
Could you repeat that?
Oh, so the woman has asked me, what about the fear of death? And have people who I've met in all my years of research talked about the fear of death? And we live in a youth-driven society. So what I have to say about that is, in all my times in the clinics, basically what I've heard people really older than the age 70 say is, I'm not afraid to die. I'm afraid of burdening my family, and I don't want to be in pain. That's, what 98% of people say. Lillian Rubin, this well-known, wonderful Berkeley sociologist who's written a number of books about family and relationships over the years, died last year, I think, or the year before, last year at the age of 89, and right before she died, she wrote 3 amazing articles. They're short in Salon.com. And she said, I'm 88 going on 89 and I'm frail. Why should I burden my children and the society with asking for more medical intervention that will simply keep me alive in this stage, in this state of not being well for a week or a month or a year? Don't I have enough worries and anxiety already at age 88 going on 89? I want to be, it's this thing, I want to be able to control the timing of my own death. I think that's why Ezekiel Emanuel wrote this piece in The Atlantic, Why I Will Not Take Medical Care After the Age of 75. People want control over this. They're not afraid of dying, they're afraid of not having control. And because we have so many options to keep going, this issue about control has really bubbled up, and now it's a national conversation.
Thank you.
Thank you.